All right, so gearing up still for exam two next week. I can't believe, I don't know about y'all, but this term is going by like so quick. I mean, it's just flying. I'm like, where's the time gone? Um, so yeah, we're still gearing up again for exam two. Your exam reviews are posted. As those recordings come in, they're being posted in the announcement as well. So you have those available to you. Um, we are going to jump into leadership and delegation today. And I will tell you this, of course, the information is essential for your exam. It is also a big part of your HESI, okay? So leadership and delegation, management of care, prioritization of care. So lots of great information. Um, it's going to cover different chapters in your book. So in your success book, it's chapter 17. In your delegation and management and patient care book, it's chapters 1 and 13. And then in your concepts book, it's 39 and 44. So you have different resources there um, for you to look at. Um, so good. Is everybody still good? Kashara, are you there? Okay. Um, any questions on the group project? Are you guys still good with that? Everybody, any issues, concerns? Not yet. Okay. Have you started it? Okay, honestly, honesty always works, right? All right, so we're gonna go ahead. We'll jump in. Got additional PowerPoint too, so a little bit more. Um, oops. Um, Sorry, forgot, lost my train of thought. So we have the PowerPoint, and then we have another PowerPoint on scope of practice, which is actually really good. We will go ahead and jump in. I'll share my screen. I have the PowerPoints for you guys. All right, so organizational charts. And I don't know if anybody has ever seen an org chart. Every company, every organization has an org chart. And what this does is kind of shows you where you fall in what I call it the chain of command, okay? Um, and so this is just kind of a really basic org chart, okay? So the owner of the nursing home, the board of directors of the nursing home, and then you can see here each one of the departments, okay? OT, dietary, physical therapy, nursing, maintenance, social services, secretarial services, activities department, depending on the size of the organization. Um, and it'll kind of, some of these may be a little bit different as well. But under nursing, you see you'll have the director, the nurse managers, the charge nurses, and the nursing assistants. So this could be, the nurse manager. They may have nursing supervisors and other people that kind of fall in there. But this kind of helps to show you what do I do if something goes wrong, or who do I report to? Who's my direct supervisor? Underneath each one of these, there will be names. Okay, so depending on how many units, you may have like 5 units, and each one of those charge nurses' names will be listed there, and then each one of the nursing assistants. So this is a real basic org chart. Some of these can be pages and pages long, depending on, again, right, the size of the organization. Your book also has a different one, which is a little bit different too, just kind of shows the nursing department, like the director of nursing, the supervisor, the manager, and then each unit. And so again, there's lots of reasons why this may be important to know, who do you go to if you're having an issue? That'll tell you your supervisor, and other things. So it's good to know where you fall in your chain of command or on that org chart. Then we get into the difference between management and leadership. So, you, of course, as a future LPN, are going to be in a leadership position, especially if you're working in long term care. You will have CNAs that you are required to supervise, make sure that your client, your residents are being taken care of um, appropriately. You'll have to delegate, you'll do assignments, and lots of supervision. So you will need to develop your management skills. Obviously, you're getting a lot of what you need here in school. And if you've never been in a leadership position before or had to direct people, building those skills is super important. So when we look at the difference between a leader and a manager. Okay. Management or managers, they're more task oriented. They are responsible for discipline, they empower and control, they instruct others. They always have subordinates, right? So an R nurse manager is going to oversee not only the charge nurses and then our other nurses on the unit, but they'll oversee also the CNAs or the UAPs. Um, they're supervisors and they're responsible for goal setting. Leaders, on the other hand, is a little bit different. The focus of leadership is to produce changes in the workplace to meet the goals of the employing agency. So they need to be more people oriented, right? They need to have motivation and be motivators. They need to have a vision or a strategy. They need to be able to listen to their employees, empower employees, because that's really important. They have followers, they're delegators, and again, more focus on goals. Than the managers are. So, again, other things managers coordinate people, time, supplies to make sure that desired outcomes in their area of responsibility are met. They have a appointed management position. So, we look, managers are appointed by their employers. So, your nurse managers, right? They have that formal title. They're appointed by either the DON or the administrators to do that role. And they have a formal line of authority as well as accountability. Um, the leadership is a little bit different. When we look at leaders, the goal here, like I said, is to produce changes in the workplace to meet the goals of that employer. Leaders it's a little bit different. They have that ability to empower and influence the beliefs, opinions, behaviors of a person. They may not have formal authority, but are still able to influence others. And we call these like our informal leaders. Has anybody heard of an informal leader before? And you may have come across informal leaders and not realize, like in your class, I'm going to use this as an example. So, like in your class, is there one person you know that is always going to know when assignments are due, or always knows where to get the information, or is always trying to bring people together to maybe study, right? There's usually one person in every group, or it could be somebody that you worked with, right, who doesn't have the official title of a supervisor or a team leader or something, but they're the resource, right? They always know where to go, where to get the things that you need. They know everybody in every department, right? They're always trying to help and do everything that they can. And they may not have that informal or they may not have that formal title, but they're a really great resource. And that's what an informal leader is. They're able to bring people together, even without the title, to try to help and do, everything that is possible. And there's different types of leadership styles. And so, if anybody has ever had a job, or even sometimes within school, you can look at maybe your DON or your assistant DON or or your campus president, and you can see there's different leadership styles that you may come across in your either employment or even in school, like I said. We have our autocratic leaders, our democratic leaders, and we have what are called laissez-faire leaders. Autocratic leaders are more concerned with the task. Your laissez-faire are more concerned with the employee. And then in the middle, we have that democratic. So they balance concern with the task as well as the employee. So if I break this down a little bit more, autocratic, think military. That's how I do it. All right. They're more like barking orders. Okay. Go clean up this room. Go give that person a bath. Go do this. Okay. They're just very straightforward. Okay. They don't share responsibility and authority with employees. Primary emphasis is going to be on policies. They basically, like I said, they're going to tell employees what tasks to do. They don't expect any feedback from the employee. Um, and we've all, I'm sure, come across people like that at some point. This is actually an effective leadership style in crisis situations, in code situations, in emergencies, right? Where we need one person to take control and direct people to do things for the safety and, for making sure that everything is getting done that it needs to get done. On the opposite, we have laissez-faire. And I don't know if anybody has ever worked with anybody with a laissez-faire leadership style, but they give away responsibility and authority to the employers. They put the employees before policies. Basically, they're people pleasers. And if, the goals of the agency, the policies aren't a consideration, this could be an effective way to lead. If everybody I'm trying to think of a good example for this one. If everybody knows what their job is that day and everything is going fine, maybe we can be a little bit lax as long as everything is getting done. But this isn't an effective leadership style for everyday basis, right? Otherwise, there is no structure, there's no accountability, don't know if jobs are getting done. But the goal here is they're just trying to make the employees happy and not really, pay much attention to anything else. And democratic leadership is the style that most people employ. All right. They share responsibility and authority with employees. They enforce the policies, but they're still concerned with their employees, right? So an emergency happens, right? Even though the policy says you got to go to work, right? We understand that emergencies happen and situations happen, but there is still, they're still going to enforce, but we're still going to have concern. They also seek input from employees and encourage problem solving. So, example, let's say for some reason, all of a sudden there's been a lot of falls on the unit. Okay. So, when we look at, okay, what can we do better? So we'll bring everybody together and we're going to sit everybody down and we're going to look and we're going to see, all right, what's going on the unit? Why all of a sudden do we have all these all these falls? And now let's sit down and think of some ways that we can do better. How can we prevent falls from happening? All right. So what are the concerns that the staff is seeing, and what are some ideas that they have to make it better, right? So they seek that input from the employees. And they're more involved with employees, and that's what a lot of managers like to do because most managers want to know what's going on their units and in their buildings to improve the culture, not only of the employees, but for the clients as well. And so this is, the type of leadership that is expressed by most people in a leadership position. It's very effective in daily nursing care situations, meetings, committees, review of care plans, right? Where it's a much more needed collaborative environment. Oops. And then we have situational leadership. And situation leadership, this is kind of where I was saying how each one of those leadership styles can be, effective in different times. And, if it's a good day, maybe I don't have to sit here and make sure everybody's doing their job and not a whole lot. So I can kind of sit back and let the employees do what they do best, right? That would be that laissez-faire. If an emergency happens, a code happens, a hurricane, a tornado, flooding, uh, a code situation, right? That's where I need to jump in and take charge. Vanessa, call 911. Seda, start compressions. Tymisha, do breast, right? Victor, you're going to be my scribe, right? So everybody, somebody is there directing, right, what everybody is supposed to be doing. Same thing in an emergency situation. Do we have to evacuate the residents? What do we need to do, right? If it's a tornado, we got to pull the residents into the hallway, right? So everybody needs to be directed so we can make sure everything is done. And like then that, democratic for just the regular everyday nursing, or the everyday, activities. So you can see, how leadership styles can change based on that situation. Um, and your leadership style, if you've not, like I said, if you've never had to manage people, assign or direct or anything, you are going to build leadership styles. And you probably already have a leadership style, you just probably haven't had to use it yet. Um, but you can, obviously everybody has worked with a leader at some point in their lives, whether it's through an employment or at school. You can see we've all probably worked with people who aren't the best leaders. Some of us have probably worked with some really great leaders that we're going to try to emulate. But you take all of that experience that you have, and that's usually what, how a person develops their leadership skills. They learn from both the good and the bad, right? And they kind of meet somewhere in the middle to make sure that they are effective. And you, like I said, you will develop those leadership skills as you start working with people. So, what do you need to be a leader? So, leadership, like I said, there's a lot to it. It's just not, assigning, and assigning tasks or delegating tasks. You need to be able to motivate, right? You need to be able to motivate team members to help accomplish the goals, whatever the goals of the day, of the week, of the month. You need to be able to communicate effectively, right? You need to be able to problem solve. Problem solving is a big part of being a leader, right? Me, even when I use that example that we're having, some additional falls, like why all of a sudden are patients falling? What's going on? You need to be able to look around and kind of see and identify some areas of concern. You need to be able to collaborate and build your team. And this is a big part. And who are CNAs right now? Anybody a CNA or worked as a CNA? Okay. So my CNAs, you guys know how important it is for CNAs to work together, right? CNAs are the backbone. Like I don't, I couldn't do my job without my CNAs. I love my CNAs. They're amazing. Not saying that I have a couple that, we're training, we're retraining. But as nurses, we can't do it all, and our CNAs are our backbones. They're their eyes and ears in a lot of situations, and being able to build that team is really, really, really important. So, you're gonna have to spend some time getting to know your CNAs as well as your other nurses. It helps you identify what some of their weaker areas are, and really build them up. And managing stress. Nursing is stressful. I don't know if you guys know that. Okay. Nursing is a little bit stressful. There's a lot that goes on. And, depending on the area that you work, it's going to determine, sorry, is going to determine your stress level. I will tell you some days, everything goes super smooth. You don't have any issues. And then, the next day you come in and everything is a mess, right? And so you need to be able to manage stress. And I'm going to tell you, sometimes it's not just your stress about what you need to do. Working with people, okay, you're going to have to work with their stress as well, right? If you have one CNA whose assignment is just a little bit heavier today for whatever reason, maybe her assignment, half of them are going out on pass, or half of them are having an appointment, or something else that, that CNA may be a little bit stressed trying to get everybody ready and may need a little bit of assistance, right? So we really need to look at each of our, who we're working with, because sometimes it's not just dealing with our stress. We have to deal with other people's stress, and how do we manage that? But motivation is one of the big ones. And we have to be able to motivate people. And sometimes, honestly, we sometimes need our own motivation, right? I don't want to go to work today. And you're just trying to think of all the different reasons why you don't want to go to work. And what happens if I just call out for today, right? We all know that that happens. But motivation is part of, why we do what we do. It's the drive that causes us to set goals, right? And we want to reach those goals. And we have different types of motivation. We have intrinsic motivation and we have extrinsic motivation. All right. So intrinsic, those increase our job satisfaction. It also increase, it contributes to our personal growth. Um, and so, things like achievement, right? Working towards, maybe it's, learning new skills, or, maybe it's moving up. You're coming from, you're a charge nurse and you want to be a supervisor or something along those lines at some point, right? It's recognition. And this is a big one that we need, and I try as a leader to always instill this. Recognition. Recognition is so important. Nursing is a thankless job. We don't get a lot of thank yous, all right? And that sometimes it's not even from our patients. Sometimes it's from our managers and supervisors as well. So just saying thank you sometimes is super important, right? Um, or having someone tell you thank you, like, hey, you're doing a good job. The value of the work itself, as nurses, you have to love what you do in order to do what we do, right? And then responsibility. This is another one. All of these, intrinsic factors have to do with the job itself. And then we have extrinsic factors. Okay. These are mostly maintenance factors or dissatisfiers. Okay. These decrease our job satisfaction. So things like the company policies, administration, supervision, your salary, your relationship with your fellow employees, work conditions. These are all dissatisfiers, right? If we're constantly running short staffed, if we, are constantly out of the supplies that we need. My CNA is how many times do we run out of linen? Like linen, linen is always the bane of my existence, okay? Why is it I can never have the linen that I need, right? Um, so, those can be job dissatisfactors. Like, my gosh, we're always short staffed. We never have the staff we need. We don't have the linen we need. I'm not getting paid enough to do what I do, right? These are some of those things that are dissatisfiers. And so, as a good leader, all right, that leader has to address both the intrinsic and extrinsic motivators in their workplace. And even our Maslow's hierarchy of needs can fall into this, right? Let's see. Talked about that. Okay. This is another one. And obviously, I know my CNAs might know a little bit more, but regulatory demands, state, that one word that could just make anybody crazy in a long-term care facility, right? Um, Long-term care, and I focus on long-term care because that's kind of where your book focuses, but long-term care is the second most regulated industry in the United States under the nuclear power program. Okay, so that's huge, right? They put regulations on every single thing in a long-term care, what we call the red book. Okay. Um, the red book is our regulation guides from the state. It's about this book. I mean, it's about this thick. It's huge. And it covers everything. It's not just nursing, like it covers, electrical and everything is in that book. Like it's not just nursing, okay? So it's not like, oh my gosh, I have to know all that, but it's a lot. And so that's another job dissatisfier. Not saying that hospitals and other things aren't regulated because we know they are, but the regulations for long-term care are just extremely extensive. And lots of paperwork could definitely be a job dissatisfier. And it's a lot, and I know that. But I always think of like I was in leadership and long-term care for a long period of time, and I loved it, and not saying that I didn't. But I will tell you, the more I got into leadership, the more I missed actually working with the patients and the clients. And so now working with just the clients and going in and just doing what I need to do. And I'm kind of back in that patient situation now. I don't know, it's much more satisfying to me. We know we've talked about communication before, but communication skills, being able to communicate effectively, those verbal skills, making sure that your verbal and your nonverbal are, match, that we're not sending those mixed messages, when you're written. So a lot of times, as charge nurses, or even other positions, you may have to write messages. I know that I used to when I worked in prior to this facility, if I had to do like an education or, an in-service on the unit for whatever reason, making sure that the communication that we're providing, it's something that everybody will understand. Um, so we try to write it in at least a fifth grade level so that everybody can understand. Always review your messages before posting them just to make sure that the intent is clear. Always read them aloud or have somebody else proofread, so that they make sense. Um, when you're doing assignments. Now, everywhere I've gone does assignments a little bit differently, depending on the number of, staff versus the number of clients. A lot of the assignments are pre-done, but you may have to move people around, make sure that they are clear, that, they know who their showers are, all that stuff. Um, if you're holding a staff meeting, or even a unit meeting. Um, do your unit meeting, even if it's verbal, and then have some sort of transcription available because, we don't work 7 days a week, right? So that information may be needed to, be presented to those that are not there. So you want to make sure that they get the same information. Um, on the telephone, depending on who you're calling, make sure you know who you're calling and why you're calling them. SBAR is super important, especially if you're calling, a provider. But let's say you're, calling a family member or you're calling a staff member. Be, aware of how you are speaking on the phone. And so Everybody should, although I don't know, does anybody really talk on the phone as much anymore? I find like text messages sometimes work a little bit better. That doesn't work for families though, right? You need to call family members on the phone. So make sure that you identify yourself while you're calling, and, provide whatever, information that you need to, and always ask, if they have any questions or concerns, and making sure that you're using those active listening skills all the time, right? Whether we're having a conversation in person, on the phone, we want to make sure you're using your active listening skills. So let's talk about team building. All right. So I said it's so important to make sure that you are building your team. Um, there's many things that fall into this. If you have a good, healthy, functioning team, then your team is more likely to stay, right? They're more likely to stay in a position where they feel appreciated, wanted, and if they're not, that's usually when people will start like, oh no, I'm not staying here. I'm going to go somewhere else. Um, I start with stress management. Um, so I'm going to ask this question. What are some things that you do to manage your stress? Anybody have anything that they
Walk
do to
away.
walk away? That's a good one. Sometimes you just have to walk away. Absolutely. I'm 100% with that. What else can we do?
Stress balls.
Stress balls. Okay. Stress balls. I don't know. I don't know if it's a texture thing, but like I don't mind the harder ones, but some of those soft ones, I can't. I don't know if, like I said, I don't know if it's a texture thing or what. I can't do the like really squishy ones. I don't mind the hard ones. What else? Anybody like to cook, take a walk, listen to music? You know what I miss? Okay, so I grew up in restaurants. When I was younger in Brooklyn, my mom owned a bar, and so I kind of grew up in the restaurant industry, and I waited tables all the way, like except for when I was in the Navy, but I waited tables up until I joined the Navy. And then when I got out of the Navy and was going to nursing school, I worked as a waitress. I miss being able to go in the walk-in or the freezer and just scream. Anybody ever work in a restaurant? No. And you can't hear nothing in those, you can go in there and scream and nobody can hear you. So, if it was a really busy day at the restaurant and, it's just crazy, I missed going in there and just like screaming. Obviously, there's not anywhere in, I don't know, I guess unless you're working in the kitchen, you can't just go in and scream somewhere. But, you have to find a way, whether it's exercising, walking, music, or some people have that one person that they call right when things kind of hit the fan and you just need to vent. So keep in mind, if you don't have one, some people crochet, color. I'm trying to think of what else I've heard. Find
Sleep.
something. Sleep. Sleep sometimes is good, right? I agree with that 100%. Sleep is absolutely another good one. But we have to find something that works for you that's positive, okay? So no drinking, no smoking, no using illicit drugs. We want positive coping mechanisms. But again, it's stressful. Jobs can be stressful. So we want to try to maintain or create a less stressful work environment as much as possible. And like I said, finding something that helps you to de-stress. So life skills that help to control stress. And so like whatever it is for you that works. Sometimes stopping and counting to 10, or, walking away or taking a break. Well, and that gives you time to collect your thoughts, ideas, right? And try to find a better solution. Another one is identifying some signs of stress. And so, like I said, and when you're working with people, it's not always the our stress that we are working with. Okay. Sometimes we have to learn, we have to work and learn, to, identify stress, within our, and, those that are we're working with. And so, you have to be able to kind of, identify those. Um, so examples of some of the dysfunctional um, job behaviors. Um, you may see some decreased performance. You may see some negative interactions. They're not communicating effectively. You may hear some changes in the way that they're speaking to other people. People are leaving, right? There's more bigger or higher turnover of staff. You may also have residents and families um, start to, complain or become unhappy. So this is, again, some of the things that we need to identify and, encourage people to talk. Um, ABCD ways of increasing awareness of irrational thoughts. So activating, right? So activating is a good one. B, belief or self-talk about the situation. Your C are the consequences. What happens if this, this doesn't happen or this doesn't change? And then D, dispute those irrational thoughts. So how do we put that into, I'm trying to think of a good example. How would I put that into play? Let's say you're working and one of the CNAs for the next shift calls out sick. All right. And you've already had two other CNAs call out. All right. So you have a CNA that calls out and says they're not coming in for their shift. All right. Well, you're already stressed out, right? Because you already had two other call outs, and now what are you going to do, right? They're going to be short staffed for the next shift. Um, And so maybe that's that belief, maybe you think, oh, well, she was probably out partying the night before, and that's why she can't come to work today. Um, and so, you may be a little bit like, yeah, whatever, bye, kind of rude to that CNA on the phone. All right. So that's not effective communication, right? And one of the things that we need to do is understand is people are going to call out sick. We don't have control over the situation. And we don't know truly what's going on. You may have heard that, oh, yeah, they went to the club last night and they were drinking and, all of that, but whatever. Again, we want to be as respectful as possible. Just say, okay, hi, right, thank you for letting me know. I hope you feel better. That's all you really have to say. Keep all the negative out of the conversation. It also decreases your stress. Yes, because now you have other stress. You have to find other people to come in and cover that shift. But you don't want to get angry. You don't want to stress out over that situation. Now, if it, I know sometimes, in the back of your head, you might think whatever it is you want to think. But just like I said, dispute those irrational thoughts. Thank you. I hope you feel better. That's all you have to say. So, some ways that you can help to create a less stressful environment as new nurses. Okay. This is something that as you are in orientation and you are learning your role, all right, you'll eventually get a good rhythm down for how your shift is supposed to go. But you always want to organize your shift. That helps to prevent some stressful situations. I said some, not all. You want to make sure that the CNAs have the, adequate resources. And I know, like I said, I always mention linen because linen's always one of the biggest issues. Um, so making sure that, the CNAs have what they need in order to get their job done, because that decreases your stress, it decreases their stress too. If they have what they need, Um, Encourage nursing assistants to take breaks as scheduled. This is another one. This is what I used to do because I usually worked really large units and I usually had anywhere between 5 and 6 CNAs on my units. And so give all the patient assignments, and I would also look to see at, who, if anybody was going to dialysis, if anybody had appointments, or, anything else. And so I'd kind of organize that. And then, of course, we have to take into consideration meal times, right? So day shift, especially, we have breakfast and we have lunch, right? CNAs need to be on the units or in the dining room for breakfast or lunch. And so we had to make sure, right, that everybody gets their break, but that everybody is available for meals. So I staggered my CNAs. um, I would send two at a time to lunch. And so that made sure that they got their lunch. And I would put their lunchtime on that assignment sheet. All right. So this is what time you're going to lunch. This is what time you're going to lunch. Now, granted, sometimes it didn't, we'd have to switch things up. But what I would do is I would have that on there for them so that they knew everybody on that assignment or everybody on the unit that day knew exactly what time all this, everybody was going to lunch so that when those CNAs were on lunch, then the other CNAs knew to cover those rooms should the call lights go off or something happen. Um, and that's, making sure that everybody took their breaks. Create a calm environment. And this is a big one. Um, we all know people that are a little bit more high strung than others, right? That just chaos seems to follow them wherever they go. But creating calm environments, I've walked on units and even as a nursing instructor, when I would bring students to clinical, I've worked on units and everybody's yelling and they're like, I'm not doing that, and I'm not doing this and this and that. And it's like, and the charge nurse is just standing there, and not intervening at all. And the charge nurse is responsible for that unit. They're the ones that you need to take control in situations like that. I've also seen walk down to other units where the charge nurse and the lead CNA are sitting there. They're looking at the assignment, making sure everything is done, and everybody just kind of knows what they need to do. And so be the nurse that you want to be, but you also have to make sure that everything is getting done. And treat your nursing assistants with respect. And I know the nursing assistants, the ones that have started as nursing assistants, they know this a little bit better. But again, your nursing assistants are going to be your eyes and ears. They can be your best friends or they can be your worst enemies. And not going to lie, so be very careful, treat your nursing assistants with respect, please and thank you. And you're going to hold them accountable to make sure that they get their jobs done, but you also want to build respect with your CNAs. Um, I am, I don't know, I was raised in a different nursing world, okay? So if a call light goes out, I answer a call light. If my resident needs to be changed, I'm going to change my resident. I'm not going to sit there and ignore a call bell or, I'm going to go get the CNA who's probably in another room changing another resident to say, oh, by the way, this one needs to be changed as well if I'm sitting there not doing anything. So I don't usually have issues with CNAs. Not that I haven't worked with some CNAs that needed a lot of direction, but um, every nurse is different. There's a lot of nurses out there that will not answer a call bell, will not change a resident, and that I don't understand it. So just be mindful of that. Your CNAs work hard. I work night shift. Okay, so I have anywhere from, it depends. I think our total unit holds 60 residents on our skilled care unit, and I usually only have two CNAs. All right, so sometimes I have an extra nurse, sometimes it's just me, but I always have at least two CNAs. And so we try to split the unit up effectively. And if it's like if call bell goes off, I'm going to answer my call bells. I can get water. I can change a resident. I can pick up the remote off the floor because you know how many times that happens in the middle of the night. It's crazy. Okay. I can do these things. I'm not busy though, well, I'm busy, but I'm not, running crazy all night long. And, there's no sense in me not helping. Um, then they know on the nights that everything is going on that I may not be as able to help them during those nights. But at the same time, they know that if it was slow, that I would be helping. So you have that relationship with my CNAs. I have a new nurse that I'm working with that I am trying to educate about answering call bells. I waited. Because I only work 2 nights a week. I work the weekends, so it's not like I'm there every day, but I've been training him for the last couple weekends, and he doesn't want to answer call bells. He doesn't want to answer call bells. And I'm like, oh, you're too young a nurse to be like this. Um, and so the other night I finally just kind of was like, look, plain and simple. Get up. You hear the call bells going off. Why are you not answering? Well, there's CNAs and it's not real busy. I don't care if there's CNAs. Like they're working too. But if you hear a call bell and it's not being turned off, then your CNA is probably busy. You know, get up and go answer the call bell. And he kind of looked at me funny, and I was like, I'm just staring at him like, well, what point? And so he finally got up and went and answered the call bell. And I said, what did they want? And I think that they just wanted some ice water. Okay. And you can go get ice water. Like, let's go. Like, I don't understand how some nurses just think that they are above that because they're a nurse. Like, we're all nurses. We all had the same training. And what's the first thing you learn in nursing school? Basic nursing care, right? So keep doing it. Like, I don't understand. But yeah, if you didn't have CNAs, what would you do? What if our CNAs had called out for the night? Guess what you would be doing? Because I'm not doing it all by myself. So you're going to be in there helping me. So we'll see how he progresses. We'll see how he progresses. Problem solving. Okay, so problem solving. Um, so I'm worked with my problem. I identified my problem as he needed to get up and answer some call bells because the call bells were driving me crazy because I was sitting there and I would have and I'm not saying why. I'm going to tell you why I didn't get up and answer it myself. For one, I had a bottle of IV medication in my hand that I was trying to mix. And just so you know, IV Zosyn, they send it, comes in a powder. You got to mix the IV bag. It clumps. It clumps. And it's very, very hard to mix. So I'm literally with the IV Zosyn pounding it against my hand trying to get it mixed, which is why I didn't stop to answer the call bell myself. But then the beeping of the call bell was just increasing my aggravation. I was like, go answer the call bell. Um, but yeah, so that's why. That's why I didn't go answer it myself because otherwise I would have. And trust me, I spent a lot of time answering his call bells because I cannot stand that call bell, bing, bing, bing in my ear, for more than like 2 minutes. Like, nope, can't do it. So anyway, we have the problem solving steps. All right. So problem solving steps are very similar to the nursing process. Okay. It's just something that we can use, to solve a problem. Which, again, you're going to solve a lot of problems as you are working in healthcare. So the first thing that we want to do is collect data. So sometimes with problem solving, we may think that one thing is the problem, but as we start to collect the data about the issue, then we realize that the problem really wasn't the problem that, initially that we saw. So we're always going to collect some information about the problem. Like, we can, figure out what we thought the problem was. And then, like I said, figure out, maybe it's, oh, I'm trying to think of a good one. I don't remember what the book problem is, but let's say maybe you don't have a great relationship with one of your coworkers. All right. And you need to try to figure out how to build that relationship. So you want to define the problem. All right. So, for whatever reason, you don't have a great relationship with one of your coworkers, and your goal is to, have develop a better working relationship. Okay. You don't have to be best friends, but you have to have that good working relationship. And then you're going to select interventions. Okay. What can I do? Right. Or, what are some things that can be done to help develop this relationship? And just like the nursing process, right? You're going to go through these steps and you're going to, do those interventions, and then you're going to go back and evaluate. Did it help? Were we able to establish a better working relationship? And if not, then need to go back to the beginning, right? And look and see what some interventions are that we could do a little bit different to try to, build that relationship. In some cases, maybe you can't, maybe it's just something that can't be fixed, but at least you tried. So again, those problem solving steps, very similar to the nursing process, but it's just an organized way, right? When something happens that you can work to try to fix the problem. All right, then we're going to go into some of the specific knowledge and skills that are needed, but let's go ahead and take a break. Be back at 3. All right. So, what are some of the specific skills and knowledge needed? So, obviously, occupational clinical skills. So, rules and documentation, the legal aspects, the federal regulations. Again, these aren't things that are, especially the federal regulations, aren't things that are expected of you as you enter practice. You will learn these as you go. Legal aspects, covered a lot of the legal aspects. Time management skills, continuous quality improvement, conflict resolution. These are things as well. Time management. Time management skills are going to be extremely important. And believe it or not, throughout your time in nursing school, I'm sure you've learned a lot about time management, right? Because you've had to schedule time to study and, work and take care of kids and, have a life outside of school. Um, but a lot of it is just being able to organize your tasks, what needs to get done throughout your shift. And again, you can use your nursing process. You can use that problem solving process as well. Um, Conflict resolution. You need to be able to manage conflict on your unit. Um, Human relationship skills, the ability to get along with and relate to people. This is, another thing. Um, some people, everybody has different personalities. This is something that, when you look at, um, getting along with people is just being able to deal with different personality styles. Anger management's another one. And not only, do we have to deal with sometimes our own anger management, okay, we also have to um, deal with issues that may occur with our CNAs and other staff members. You'll be responsible to evaluate your nursing assistants, so you'll contribute to their performance evaluation. We talked about empowerment, increasing self-confidence in team members, and being non-judgmental. This is really important. As a leader, as a charge nurse, okay, empowerment is really important. And increasing self-confidence in team members. Just like I was saying, I work with new nurses, and that transition into practice. But it's also, maybe if they're not confident in some of their skills, teaching them, right? Being encouraging and being that role model for them. That helps to increase their self-confidence, right? It helps them to perform better. So sometimes we just have to take time away, and put that into those that, put that time into those that we're working with. All right, so let's get into assignment versus delegation, all right? So, assignment, all right? When we look at assigning something, assignment is just the distribution of work that each staff member is responsible for during their given work period. All right, those activities are consistent with their job description, their legal scope of practice, their educational background. The staff member assumes responsibility and is accountable for completing the assignment. So an assignment is, all right, so you have 5 CNAs working on your unit, and each one of those CNAs is assigned to a specific group of residents. So they're responsible for providing their care, their ADLs, depending on where you're working, right? It may include vital signs, whatever. Okay. So it's according to, right, their job description and position, their legal scope of practice. So when we talk about that State Nurse Practice Act, knowing what they are allowed to do within your state, as well as your policy and procedures um, of your facility. So what I mean by that, like the company that I worked for, Even though CNAs are trained in Virginia and here, but I'm going to use Virginia as an example. Um, CNAs are trained to do vital signs, but the company that I worked at, CNAs did not do vital signs. Okay, so you not only have to know their scope of practice, but you have to know what they can do under your or within your organization. Down here, okay, the CNAs can get vital signs, right? So it just depends on where you're working as to what they can and cannot do. So you do need to know that. Delegation is a little bit different. Okay. So delegation is the transfer of responsibility for the performance of an activity from one person to another while accountability is retained by the delegator. So let's say I ask that CNA to go get vital signs. Okay, it's not part of their assignment, but they can do it. So I can delegate that vital signs to that CNA. All right. It is still I am asking the CNA to do those vital signs. Okay. But I am still ultimately responsible if they don't do those vital signs. Does that make sense? So I'm still responsible. So with assignment, they're 100% responsible. If they don't turn and reposition, if they don't clean their residents, if they don't bathe their residents, if they don't get them up and dressed and all of that, that's on them. With delegation, if they don't do the vital signs, that's going to be on me. Um, Delegatee, so the person that I am delegating to, they have to accept or agree to the delegation. So if I were like to say, hey, Tamisha, go get Mr. Jones and Mr. Smith's vital signs for me. And she can turn around and say, I can't do that right now. So she's denied that delegation. Okay. But otherwise she can say, okay, yeah, no problem, and grab the vital signs, right? And go do the vital signs. So they have to agree to the delegation. Why do we delegate? For one, nursing is not an individual sport. Can't do it all. You can't do it all. It is absolutely a team sport. And so it's a strategy that we use to make sure that client care has been done. It also helps to improve client outcomes and satisfaction. All right. So, and yeah, sometimes it's something extra for the CNAs or somebody else. I shouldn't just say CNAs because we can delegate to others, but it is just a way that we can manage our time a little bit better to make sure that our clients are taken care of, our patients are taken care of. So, where do we find this information for delegation? Okay. So, Nurse Practice Act #1. Okay. You have to know your Nurse Practice Act. You have to know the Nurse Practice Act of your CNAs or your UAPs or whoever it is that you're delegating to. You have to know if it's in their scope of practice, right? So, I'm not going to go ask a CNA to hang an IV, right? Because that is definitely not within their scope of practice, right? So, you have to be really careful with that. So your State Nurse Practice Act that can provide guidance for legal delegation and its regulations. Now, we do know that there are some states that do not allow for LPNs to delegate. So it is something, again, you have to look in your Nurse Practice Act. It's not a required act. This is not something that you have to do. All right. Um, I have some CNAs that, they are perfectly content with, just taking care of the residents. They don't want to do anything else. I have other CNAs that are like one, she shocked me. She was like, "Can I do your vital signs for you?" And I was like, I mean, if you really want to, like, don't, if it's not going to put you behind in your work and you want to like help with the vital signs, that's perfectly fine. But it just really depends. Again, it's not required. The state board of nursing, again, you can go to your board of nursing and look for guidance about delegation. But this, like I said, you have to know the legal scope of practice for your UAPs or your CNAs as well to make sure. Other resources, so you can look at your rules and regulations from your board of nursing. You can look at NAPNES, the National League of Nursing, the American Nurses Association, or your National Association of Licensed Practical Nurses. There's a variety of different things that we're going to give you that can give you guidance as far as delegation of duties, as well as, again, organizational policies and procedures. So best way I can describe this is, right, the Nurse Practice Act, that's your umbrella, okay? And you can't work outside of that umbrella. Your organizations can limit what you can do, but they can't go beyond that umbrella. All right. So, um, like we know nurse practice acts, nurse LPNs can't push IV medications. You can hang IV medications, but you can't do the pushes, right? So an organization cannot come and say, "Oh yeah, we allow LPNs to push medications." No, because it's in your nurse practice act that says that you cannot do that, okay? um let's say, and so they can't go beyond that umbrella, all right? Or another example would be, you know that you can do IV medications, just not the pushes, but maybe your organization says, okay, LPNs are not going to do any IV medications. That's going to be the responsibility for the RN. Okay, so they can't go beyond it, but they can limit. And that's the same thing for CNAs, like I was saying with the vital signs, right? We know CNAs can do vital signs, but some organizations may say, no, we don't want the CNAs doing it. Only the nurses can do vital signs. So here, these are really, really important for you to understand, okay? These are the 5 rights of delegation, all right? So right task, right circumstance, right person, right direction and communication, and right supervision and evaluating. Can't say the word, okay? So we'll start with right task, okay? Delegated tasks must conform to established guidelines, meaning that it has to be within their nursing, their scope of practice. Okay, they can't go out of their scope of practice, and it can't go out of the policy and procedures within your organizations. Okay, so you have to know that. um, with the right circumstances. And so, right circumstances is something you have to pay attention to. You can't just delegate without laying eyes on your patient. Okay, so delegated tasks do not require independent nursing judgment. So, um, the let's say your client needs to be stable. Okay, there can't be something critical going on with your patient, so you can't delegate something like that. You're not going to, your patient's crashing, you're not going to have your CNA and go do vital signs. Okay. um, or if we're understaffed, or if the CNAs are already understaffed, and putting extra duties on them, is going to cause stress, right? So right circumstances, the right person, decide who is qualified and competent. All right, now all CNAs go through similar training programs, just like nurses go through similar training programs, right? That doesn't mean that every CNA is the same. All right. So as you work with your CNAs, you are going to realize what their strong parts are, what some of their weaknesses are. And it's not always the CNA that's been the CNA the longest that's the best either. Okay. So you really get to know your CNAs. But they need to be able to communicate effectively. They, be able to perform those tasks safely, accurately. They're also someone, if something, is maybe needs to be clarified, that they are going to seek guidance and direction when it's appropriate. The right direction and communication. This is a big one too. So when you're looking at direction and communication, you need to use your effective communication. You want to provide a clear explanation about the task and the outcomes and when they should report back to you. All right. So it's not just telling a nursing assistant what to do. All right. You want to be very specific about what you want done and when they need to come back to you. So, Tymisha, go get Mr. Jones's vital signs. And then once you're done, bring those vital signs back to me. They can't make an independent judgment. They haven't been trained for that. They and I'm not saying they don't know, okay, but that's not within their training. So they're not necessarily going to know if that blood pressure is really high, it needs to be rechecked. They may not know if a glucose needs, is off, right? So clear explanations about what the task is and what should be reported back, and then the right supervision and evaluation. All right. So you're going to go back and evaluate to make sure it's done. So obviously, if the vital signs or glucose level, they're bringing that back to you. But let's say, um, I'm trying to think of a good one. All right, Mr. Jones has an appointment at 10 a.m. It was something that came up last minute. So tell your CNA, hey, Mr. Jones needs to get up right now. He needs to get, quick bath. He needs to get dressed. They're coming to pick him up for a last minute appointment. They're picking him up at 9:30. He needs to be in his wheelchair ready to go. All right. And so right before 9:30, you're going to go check to see if Mr. Jones has been, bathed, dressed, and sitting in his wheelchair ready to go. So that would be an example, right, of going back to evaluate. Um, and then what happens if Mr. Jones isn't up and ready in his wheelchair at 9:30, right? You're going to have to provide feedback to that, to the UAP as to why Mr. Jones isn't up and ready, right? So these are some things that you're going to take into consideration. You're going to, if they did everything correctly and everything is good to go, then you want to also provide that positive feedback to your CNA or your UAP and be like, hey, thanks for that. Um, if you don't supervise adequately, all right, and something happens, that's where we worry about if there's any kind of client harm or anything that is, going to be you're responsible for that action. So we delegate because, right, it helps to increase your effectiveness as an LPN, as a charge nurse. It helps to reach our client goals in a cost-effective manner, and it also helps the nursing systems increase and improve their job skills. All right, so that is something that you want to grow your employees, right? Nobody wants to be stagnant. And in the process of working with your CNAs, I've pushed many of my CNAs to go back to nursing school. Like, you're really good at this, you're really good at, what you do, and you're really smart. Like, why are we not in nursing school? If that's something that you really want to do. And like I said, it helps them improve their job skills as well. So we're gonna keep talking about it. So before you delegate, all right, you're gonna lay eyes on your patient. All right. So you need to assess your client, making sure that they are stable. You're not going to delegate anything on an unstable client. CNAs cannot delegate. All right. So if they overhear, you talking and, okay, I get vital signs, and a CNA can't turn around to another CNA and say, hey, go get those vital signs. They cannot do that. They can't delegate. They also can't transfer the delegation. So let's say I asked Tamisha to get those vital signs, and Tamisha's like, yeah, no problem. I'm going to get those vital signs on Mr. Jones. And as she's walking down the hallway, she sees Vanessa and say, hey, Vanessa, go get vital signs on Mr. Jones for me. They can't do that. The delegation cannot be transferred. Once Tamisha accepts that delegation, it's going to be her responsibility to complete those vital signs. Now, like I said earlier, you can refuse delegation. So if Tamisha says no, I don't want to do those vital signs, ask why. I know, that's just a curious thing. Like, why are you not willing to get those vital signs? Um, it has to be voluntarily accepted. All right. So Tamisha just might be really busy at the moment, and she's, maybe Mr. Jones is getting ready to go for an appointment. Mrs. Smith has, dialysis, and Mr. Johnson's like, I really want to go to this activity. Get me up out of bed. Right. She might just have a lot going on at the time, and she can't take the time to do the vital signs. Um, and then there's sometimes where, they just don't feel like doing it. Okay. So you want to ask why. Why are we not accepting the delegation? So we need to, That again, they have the ability to refuse. Again, it has to be voluntarily accepted. So, other legal stuff with delegation. Delegate only if you're allowed to. So again, remember, you're going to look at your Nurse Practice Act to see if you were allowed to delegate. Some states don't allow LPNs to delegate. Determine how stable your client is, and then delegate duties for which nursing assistants have demonstrated the ability to do. Now, if I have a nursing assistant that hasn't done vital signs in 10 years, probably not the best person to go do vital signs, right? So, this is where you have to kind of know um, what the abilities of your nursing assistants are. You're going to provide specific, objective, clear-cut directions to the nursing assistants for those duties. You also will need to provide assistance and instructions when you delegate a duty. Monitor the activities of nursing assistants when they carry out delegated duties, reminding or depending on the nursing assistants and the situation, it can mean anything from being right there to a periodic check. Um, so let's say it's the first time you're delegating a duty to a nursing assistant and maybe you don't know them as well as you would like to know. You may watch them do it the first time you ask them to do it. There's nothing wrong with that, just to make sure that they know what they're doing. And then after that, you don't have to, maybe you won't have to watch them. You can just do a follow-up. If something is not being done correctly, you need to stop and don't allow it to continue. And then evaluate the safety and the effectiveness of duties that you delegated after that task has been done. And then so some of the legal parts of this. All right. If you delegated properly and you monitored and the client was injured, the nursing assistant is also liable. Okay. So let's say I'm trying to think of something. Probably. All right. Um, oh, I missed the line. Let me do the first one. If you delegated improperly and a resident was harmed, you are liable. So let's say you told your nursing assistant to start an IV medication, which we know that that's not going to happen. But let's say you did that. Let's say you told your CNA to go start the IV medication and that resident was harmed because you had the CNA start the IV medication, okay, then you are going to be liable for that because you delegated improperly. All right. If you delegated properly, like, hey, go get vital signs on Mr. Jones and the client was injured in the process, then the nursing assistant is also liable. You are still liable because you delegated that duty, but if the CNA didn't do it properly, then the CNA is also going to be liable for that situation. Okay, so it's a little bit different. If you delegate improperly and the resident was harmed, you are going to be responsible for that. If you delegated appropriately and the resident was harmed, the CNA is also going to be liable. All right. So again, be really careful with that. Um, and if you delegate, I mean, you can always collaborate with the RN, right? Hey, is it okay if I delegate these tasks to CNA? Then sometimes, that is option, for you as well. Um, Again, you're always going to follow the five rights of delegation, the right task, right circumstances, right person, right direction and communication, and right supervision and evaluation. Do not deviate from those five rights of delegation. So here are some of the things that we can delegate. Okay. So personal care, including hygiene, dressing, toileting, grooming, skincare, feeding, hydration, basic restorative skills. So transferring, positioning, ambulation, maintaining range of motion, INOs, vital signs, height and weight, and then assistance with elimination, including catheter care, fall prevention measures, applications of heat and cold, infection prevention, and urine and stool collection. Now, I've never actually asked a CNA to collect urine or stool. I've always done that myself, but you can delegate that to your CNA. All right. So these are some specific things that you can delegate. What you cannot delegate to a CNA or a UAP, complex sterile technique procedures. Okay. Nursing assistants do not have in-depth training in sterile techniques. Okay. So they can't put a Foley catheter in. All right. Um, they can't do trach care, but you guys can suction. Okay. You can use suction. Suctioning is, using a Yonkers, is oral suctioning is perfectly fine. Somebody is gurgling, you can go in there and suction them out. Crisis situations, you can't delegate. You must be there in a crisis situation. So a resident who develops chest pain, you're not going to tell your CNA or your UAP, hey, go check out Mr. Jones. He's having some chest pain. Okay, you need to be there. Now you may have your CNA with you, right? Because may need assistance with Mr. Jones, but you're not going to send them in. Initial education by an RN. Most states, LPNs can reinforce initial teaching given by the RN. So the RNs will do that initial teaching and the RNs will do the reinforcing. Although nursing assistants can collect simple data, they've not been trained to make decisions about or interpret the data. Okay, so if like this is what I was saying earlier, they don't know if that blood pressure is really off. Okay, and it needs to be rechecked. Same thing with that glucose level. Okay, so they literally are just going to perform the task and report back to you the results of that task. When delegating, the responsibility must be within their authorized scope of practice. Again, you're not going to have them do something that is not within their scope of practice, right? You're not going to have your CNA pass meds or start a Foley or, start an IV. It has to be within their scope of practice. Now, I'm going to tell you where I work, it's really interesting. A lot of my CNAs are also med assistant, not what are they called? They're not
Med
Met
techs.
text.
med techs. Thank you. I'm like, what is that called? So it's like one day you'll come in and they're passing meds, and then the next day you come in, they're working as a CNA. So it's like sometimes you get a little confused. You're like, okay, can you give medications or can you not? Because depending on what their role is for that day. So that does kind of mess me up. That has messed me up a little bit. I was working one night and a pharmacy came in and dropped off medications while I was working with a patient. And I came out and I saw the bags of the medications on the counter. And I was like, all right, I'm like, wait, I'm like, where did the pharmacy guy go? He's like, oh, he already left. And I'm like, well, who signed for the medications? And he's like, I did. And I'm like, because I'm a med aid. I was like, okay, forgot, so like sometimes it gets confusing. I haven't had that issue like in when I worked in Virginia, I didn't have that issue. They were all just CNAs. But yeah, so that was new for me. And I was like, what do you mean you signed for the medications? Like you can't do that. And yeah, so yeah, that was nothing. That was new for me. Um, and so I have a whole nother PowerPoint that we're gonna do practice questions. So don't stress. Other things as leaders. Okay. So I think we talked about this. Your role as an LPN is the roles for our LPNs are always expanding. Like there's so many different opportunities that you have now. You guys are first line leaders in long-term care. LPNs are charge nurses. You are, in charge of that unit. So most of, depending on how your unit is set up, so they may have a charge nurse and then a med nurse. Or in how it works down here is we have the charge nurses. We have on each unit, we have, a charge nurse for each hall, and then they have their med aides that pass their medications, and then their CNAs. So those charge nurses are responsible for their units. So developing your leadership and management skills is super important. You need to know your mission statement. And I will tell you that mission statement is really important, and all organizations have a mission statement that define the purpose and the goals of the organization. And so as a member of that team within that organization, you're going to help work towards that vision and lead your members, right, in being committed to that vision. When you are going for a job, all right, um, so when you're getting ready, and not going to go into a whole lot about this, but when you're getting ready to find a job, always look at the organization's mission statement, their vision, their purpose, whatever it is, and make sure that their vision statement aligns with your goals as well. And this is, because there's been times where I've read vision statements and I'm like, I don't like this. And so just be mindful of that. Again, I cannot tell you. I know I probably said it like 100 times this class alone. Know your Nurse Practice Act, know your Nurse Practice Act, know your Nurse Practice Act. You need to know exactly what your roles and boundaries are. Because you also don't want to work into an organization that may ask you to do something that is beyond your Nurse Practice Act. Jobs descriptions for your charge nurse role. It says experience is usually requires a minimum of 1 year. I'm going to tell you this depends on where you go to work, and how their organization is run. So, like I said, where I work now, med aides are the ones that pass medication. So all LPNs hired regardless of their experience as charge nurses. Okay, so you go in, and after orientation, you're responsible for your unit. But again, it depends. Okay, like I said, some organizations are set up a little bit different where a lot of the LPNs will come in as med nurses first, get that job, and then as positions open, they are available to move up. You need to have your license in your state of practice. Again, go for that multi-state license, right? Um, And then some of the standards, you need to be able to collaborate with the IDT. You need to be able to assist the DON in new employee orientation. And you are, again, responsible for evaluating the nursing assistant performance. Oops, I'm sorry, my mouse got stuck. Um, and some of this may sound a little overwhelming. But I promise you, like it sounds overwhelming, but once you start working and you get into your flow, it's not as overwhelming. But you need to know the conditions of your residents at all times. So again, not something you're going to know the first day, right? As you work with your clients, as you review charts and record or, things, you'll get to know your residents very well. Um, but it is important that you know their conditions at all times. You need to assign tasks to nursing assistants, provide care within the scope of practice by policy and under orders, assist the physician with therapeutic and other procedures, depending on how your organization is set up. You may have to do rounds with the healthcare providers, or you may even have to do rounds with the wound care provider in depending on how, but a lot of places have like, wound care nurses that do that, but you never know. Um, Recognize symptoms of any adverse developments and report those. So this is where knowing your residents is really important. You'll be able to pick up on any subtle changes that occur. Do meds and treatments, do your documentation, making sure you're appropriate and organized care within your department, delegate, maintaining a safe environment, maintain patient privacy, and of course, dignity for our patients. Other things, the facility organization. So know your org chart, your chain of command. Most places do annual skills fairs. where they just go and they evaluate your skills. So, you know, IVs, blood draws, trach care, wound care, Foley's, and, catheter care. I'm trying to think, they may do like IV dressing changes. I used to run skills fair, now I can't think of it. CPR. Um, it just depends, but you should be given a skills checklist on hire. And that will show you the skills that you're responsible to be able to do, job descriptions, and then the regulations. So, the state or the Department of Health and Human Services, that's who we call state. HIPAA. We also have CMS, which is the Centers for Medicare and Medicaid. They have specific guidelines that must be met as well. Joint Commission. Not all facilities are Joint Commission. So, and down here, we're not Joint Commission at all, but the company that I worked for in Virginia, there were 7 long-term care facilities. There was a couple assisted living, and out of all of the facilities, only one of them was Joint Commission. So Joint Commission is a separate sort accreditation. It's like a gold standard, but long-term care, you don't have to be Joint Commission. Again, it's just a joint, it's just a gold star. So we only had one facility that we, had Joint Commission. It is also another additional fee for the facility. So, you know, not, can be pretty expensive. Your national patient safety goals, and then other accreditation standards. So like hospitals, they can be joint commissioned. There's another one called DNV. I think it's out of, is it Sweden or somewhere is another one, that before I left Virginia, a lot of the hospitals had switched from Joint Commission to DNV. It's just a different accreditation, but you'll know where you're working, what the accreditation standards are, so it won't be a surprise. Oops. Other things, I'm not going to go through all of these, but the personnel policies, um, you know, everybody wants to know about paid time off, the break rules, smoking policy, uniform policy is always the big one, right? Is do I have to wear a specific color, right? Depending on my role. Um, the routines, the reporting, any special procedures, the admit, discharge, transfer process, death procedures, forms and authorizations for procedures, and then safety. This is a big one. Safety is always a big one. Um, Long-term care, I'm just going to tell you, we don't use side rails. We don't use chair and bed alarms. We don't use restraints. Now, the only time that I've seen side rails used, and it's a little bit different, if we have a hospice patient, okay, hospice for whatever reason brings in their own equipment, beds, mattresses, oxygen, suction, like everything. They bring in their own equipment. So a lot of their beds have side rails. Okay, so in that situation, you could use the side rails. Okay, because hospice is different than just traditional long-term care, right? Long and skilled care. But we don't use chair and bed alarms in long-term care. You can use them in the hospital, but we don't use them in long-term care. Again, no restraints. How the oxygen system works. Now, I've worked in long-term care facilities where the O2 is actually built into the walls like you have in the hospital. But most of us use oxygen concentrators, so you have to know where you can get a concentrator or an oxygen tank. Back safety, body mechanics, door alarms. So our facility here has a memory care unit. Okay, so all the units are on memory care. It's locked. They can't get out. Are We don't use wander alert. So even if we have like another, like I guess if they have a long-term care resident that's a want like likes to walk around or something like that, or even I guess on my side, if they, decide they want to get up and walk around, that's perfectly fine. All our doors are locked. So if we do have a wandering resident who is not really a wanderer, just wants to walk, they can't get out of the building because the doors are all locked. Um, So, but you do need to know obviously how that works. Is it a key alarmed? Is it a touchpad? However that works. You need to know about standard precautions. You also need to know about safety or security and smoking policies. Most facilities, or like all facilities, I think now are non-smoking facilities. But like we still do smoking evaluations. I don't have any residents that smoke, but we do safe smoking assessments on all our patients. The one facility that I worked at that we allowed residents to smoke, new state guidelines said that we provide them with a smoker's jacket. Smoker's jacket is something, I think that was what it was called, but basically
It's just
it
a
was like
big
a
white
drink.
apron.
Thank you. I was like, what is it called? It's like a fire retardant apron that you put on them so when they go to smoke, that they don't get hurt or burnt or anything like that. Um, but I don't think a lot of facilities, like we have one on the long-term care unit only because I see him all the time. He is a smoker. He is alert and oriented. And he even can code himself in and out of the building. And so he'll go up to the corner and he'll smoke his cigarettes and then come back to the building. So I'm not sure. I don't know if that's like, I think he's the only one of, well, I work night shift. So he's the only one I ever see doing it. So I don't know if anybody else does. Um, Talked about respiratory equipment, things like that. Where can you find a suction machine or whatever in the event that you need it, how to order the food, the different types of diet, is there any food stock on the unit, what are the processes for dining room, um, and then you'll have to know all the CNA procedures, what they can and cannot do, what their normal assignment looks like, ADLs, bathing, oral care, making their beds, blood pressure or vital signs equipment, catheterizations, specimen collection. I'm going to tell you this right here, the blood pressure stuff, okay? This was new for me when I first moved down to Texas. I'm so used to working in facilities and you have vital signs machines, right? So I start working, I'm in orientation and I do skilled care. So your skilled care patients, we do like shift, every shift does vital signs. And so I'm like looking around because I had my vital signs list and the nurse that was orienting me, they're like, what are you looking for? And I'm like, a vital signs machine. And he looks at me, he goes, what's a vital signs machine? And I was like, wait, what? Like, what do you mean, what's a vital signs machine? I said, little thing you pull from room to room that takes the blood pressure. He goes, oh, we don't have those here. And I was like, so how do we do vital signs? And he opens his bag and he pulls his own blood pressure cuff and his own thermometer and O2 monitor or his own pulse ox. And I'm like, are you for real? And he's like, yeah, we don't have that equipment. So thank God for Amazon because, was able to order all my stuff off of Amazon and have it the next day. So know your equipment, know what you have available. If you have patients that are in isolation, there should be disposable equipment in those rooms. So they should have a disposable stethoscope, disposable blood pressure cuffs, those kinds of things. Some facilities are really good with that. Some are not so great. Same thing with the thermometers. They should have their own thermometer, right? So that we're not going in and out of a room with the equipment. Of course, medications, your equipment, how to order the unit stock. So long-term care is a little bit different than the hospital. All right. In the hospital, you have the big old Pyxis machines that you go up to the Pyxis machine, you pull the medication for your patient, go into their room and give their medication. Long-term care, we use med carts, right? So we have those big med carts that we push up and down the hallway that has all the patient's medications in there. There is a unit, so I don't know when this switched. I mean, I remember, but I don't know exactly how long it's been. Um, Even if a patient was on like a vitamin, like they were on vitamin C, or if they were on Tylenol, right? All of that used to come from the pharmacy. And then finally, we got a little bit smarter about it and we have unit stock. Unit stock is like your vitamins, your minerals, your Tylenol, your ibuprofens, your Zyrtec and some other stuff, right? Lidocaine patches, anything basically that can be purchased over the counter is going to be your unit stock. And that can vary from facility to facility as well. Um, there is a lot of them will have like a similar Pyxis as well for emergency medications. Like, let's say, Mr. Smith runs out of his metoprolol, okay, and pharmacy hasn't delivered it. You can pull metoprolol out of the pharmacy or out of the Pyxis machine. Or if we got a stat dose of a pain medicine or an antibiotic, okay? You can go and you can pull it from there. It's limited as to what's available, but you can pull some stuff. You have to count your narcotics every shift. Um, every one of those med carts has a locked narcotics drawer, and of course, the narcotics have to be accounted for. So you have to count them. Both nurses count at the end of in the beginning and the end of every shift. And if there's like Ativan, there's a couple of narcotics that have to be refrigerated. So there's usually lock boxes in the med rooms in the refrigerator that if there's anything in there, make sure that you count that as well. Um, Documentation. All right. Whether you're most places are have some sort of an electronic health record or EMR system. So make sure that you know what the required documentation is. There's different documentation for different things. Okay. If they're on a antibiotic, then we do documentation every shift. If they've fallen and they're on neuro checks, that's going to be a different documentation. So you're going to learn what you need to do for, each thing. Incident reports. Okay, if somebody falls, if something happens, you need to know that process as well. And then the lists. The lists are never ending. I feel like who are the wanderers? Who has hearing aids? Who has dentures? Hearing aids and dentures are the things that go missing and lost, and glasses. Dentures and hearing aids are the things that disappear the most often in long-term care. Not gonna lie. They take their dentures out, they wrap them in a tissue. I don't know why they want to wrap them in tissues, but they always want to wrap them in a tissue and put them on their tray. And then the tray goes down to dietary, and then that gets thrown in the trash can. And guess what? Now you're digging through the trash can because Mr. Smith lost his dentures. Been there, done that many times. Okay. Hearing aids are another bane of my existence. Okay. You're supposed to take them out at night. They have a nice little case that the hearing aids are supposed to go into. You're supposed to pop batteries out and put them in the case. The case has a desiccant in there. It helps to absorb any moisture from, being in their ears all day. I don't know why. They leave them in, they get lost in the bed sheets, they get wherever. They're everywhere but where they're supposed to be. So one facility that I worked at, and this was such a pain, and I'm not gonna lie, I hated the process, but it worked. The 3 to 11 CNAs, and I felt bad. Well, I never worked 3 to 11, but I just know that this had to stink. They had to go and take every resident's hearing aids out, put them in the containers and lock and give them to the nurse so the nurse can put them on the cart and lock them up. And then the day shift, when we would get there in the morning, the CNAs and we would go around and put everybody's hearing aids in. That was the only way that we could keep the hearing aids like safe. Dentures, we never figured out a process for. Um, but dentures are expensive, so you want to pay attention to your residents that have dentures and try to prevent them from getting lost, misplaced, whatever. Um, any required state and federal forms. I'm going to tell you, I don't have a lot of, there's not a lot of state and federal forms that we'll fill out at the nursing level. That's usually for like the DON, the administrator. They may have specific forms that need to be completed. It's not something that we normally do at the unit level. Um, Collecting data. So I mean, you guys know assessment is going to be something that is going to forever be part of your job. All right. So be mindful of that. As you get to know your residents, like those long-term care residents, especially if you're working with long-term care residents, you see them every day. You're going to work with them every day. You're going to recognize those subtle changes in your patients very quickly. Whether it's, super subtle that maybe nobody else would even pick up on, but you will, I promise. Um, but we also want to look at, are they sleeping? Are they getting rest? Are they getting up? Are they moving? How do they get up? How do they move? Are they one person? Are they two-person? Are they, do they need a Hoyer lift? Do they need, are they in a wheelchair? Like what their mobility is? How can they move around? Hygiene preferences is another one too. Some people like to take showers in the morning. Some people like to take showers in the evening. How often do they normally shower? How they communicate, sensory perceptional, like if they've had a stroke, right? Have they had any vision changes related to their stroke? So we need to know that. Of course, their cultural and religious preferences, their psychological status. I don't know what's going on because it's summertime. And normally, a lot of people have like the seasonal affective disorders, but we have had multiple suicide um vocalizations lately. Like we've had like three or four where we've had to send them out for evaluations. So I'm not sure what's going on. But we have to pay attention to that. And suicide in the older adult and because you guys take Jerry, right? You took geriatrics, right? So you know that suicide is in the older adult, they're more likely to complete it. It's more likely to be violent, right? So we have to take those vocalizations seriously. But I think it's like really, I'm like, I don't know what's going on. Like all of a sudden we've had this. It's been more prevalent lately. Encouraging responsibility. So when we are, working with your CNAs, you want to, of course, like I was saying earlier, empowerment, right? Teach them things, CNAs want to know. Especially the ones that are, you want to push them to go back to school, right? You really want to encourage them. Have them help you with your procedures. This is something that I've always had. Like if I have to put a Foley in, grab a CNA, have them help so they can watch and learn. But if it's something that, within their scope of practice that they are going to do that maybe they're just not great at, do the see one, do one, teach one method. This one works so much better than, so let's say maybe they are having trouble working the Hoyer lift. Okay. Go in there, okay, with, two-person. So go in with an experienced CNA, all right, and show them how, show the newer CNA how to use the Hoyer lift. Okay. So that's showing them. All right. And then you're going to have them go in with an experienced CNA and do it. All right. And then you're going to have them teach another CNA how to do it. So see one, do one, teach one. The more you do something, the better you get at it. Okay. So, and it kind of uses all, right? It uses the visual, it uses the auditory, uses the tactile learning. So you kind of get a combination of all of it. And know that, show them that you're there to help them, that you're not just going to be like, oh, and just go figure it out, right? You want to show them that you really care about them learning and, getting better at their jobs. And then always reinforce a job well done and redirect when opportunities remain. So not everybody is going to do everything great the first time, may need a little bit of additional help. But always, if somebody does something right, it doesn't matter who it is. If it's a CNA, if it's a, another nurse you're working with and they did something really well, say good job. Um, if it's not done correctly, then we go back and we start the process over again. Okay. What could we do better, right, to get better outcomes? All right, this last problem. So employee home problems. So like I said, not only do you have to deal with yourself and you have to deal with this, the clients in your unit and delegation and managing and all of that wonderful stuff. Okay. Sometimes we have to deal with employee issues as well. So employee home problems. All right. They have a sick child. They're in the middle of, a sticky situation with a significant other, whatever it is. Okay. You want to be empathetic, not sympathetic, just like with our clients. You don't want to feel sorry for them. You want to understand what they're going through. Okay. That it's a difficult situation for them. Don't counsel. Okay. Don't give advice. Just like we say, don't give any nursing advice. Don't give advice. All right. Remember, just, you can refer for resources. A lot of organizations have resources, employee resources that you can refer them to, but you don't want to counsel. You don't want to own the problem. Again, you may have to escalate it. Maybe it's something that you can't handle at your level. So maybe you're going to refer them to the DON or to human resources, whatever it is, and suggest those other resources. And they're not your friends. I'm going to tell you, I don't know how many people have run into this and or not, but your coworkers are not your friends, I promise. Okay, they're not your friends. Because in a sticky situation, guess what? It's going to be about me, not about you. All right, I promise you this. And I have an example. So I was actually watching I do watch like some podcasts and stuff like that, but there was this one story. It was four nurses. Okay. Two of them were newer nurses, two of them were older nurses. Like, and when I say older nurses, like they've been nurses longer or not, they're old. Okay. So anyway, two of the newer nurses, and I mean newer nurses, like one of them had only been a nurse for like 6 months. Um, they were sending pictures and derogatory remarks about a patient. Okay. And it was a group of four nurses in this group text. And now the two newer nurses, they were the ones that were really making the comments. The other two nurses they had not commented on the pictures or the remarks. Now, mind you, they all thought they were all good friends, right? The two nurses that had been nurses longer reported the other two nurses for the pictures and the remarks, and the two nurses lost their nursing license. Okay. Your coworkers are not your friends, I promise you. So be very mindful when you're, working with these patient or with your coworkers. You can have a civil relationship, you can be, cohesive on the job, but just mindful, be careful what you say and what you do, because if it comes down to it, right, they're going to look after themselves. They're going to throw you under the bus. Working with difficult families, and I don't know, I'm going to stop sharing. I don't know if it's some of them are going to be difficult because they just want to be difficult. Okay. That there are those situations where no matter what you do, nothing is ever going to be right. But we have to look at this from a different angle, okay? And someone who's been doing this for a really long period of time. There's lots of reasons why families act the way they do. Okay. And sometimes they are absolutely correct in how they are feeling. Others, it's a little bit exaggerated. Okay. So think about the family now. I know how I felt. Like my mom did not go into nursing home. I took care of my mom until she passed. Okay. She didn't, her was like, she's like, I don't want to go into a facility. I don't want to die in a hospital. I'm like, and I knew this. I knew this was, so there was no way. But I had the availability to do that. Okay. Not every family has the ability to keep their loved one at home. And that's why these facilities are out there. It's why we have long-term care facilities, right? Either they don't have family that can care for them, or their family doesn't have the ability to care for them. That's still going to cause some guilt. Okay. So if everything is not perfect, you'll notice that these families pick a lot more. Like, why hasn't my mom gotten a shower today? But she doesn't like this. And why are we doing this? And right. So there's that. We also have our dementia patients, and this is a whole nother world for people. Okay. I'm going to tell you, someone that has worked with dementia patients, has an extensive. I've actually done. My original doctoral project was actually on Alzheimer's and dementia. Okay, but I switched. But anyway, so I've done a lot of research. For the most part, unless they have another comorbidity. Okay, so just dementia and Alzheimer's, they are perfectly fine. They're not in pain. They are where they're at. They are happy in their world. They are wherever they are, okay? They are happy. Dementia and Alzheimer's is worse on the loved ones. Okay. Why? Because they don't recognize us anymore. They don't know who we are. We can't talk about the days when the good old days, right? And that hurts even more. Okay. And then when things aren't even perfect with their care, like that starts that, well, you're not taking good care of them and we shouldn't have put them there and you're not doing this right and you're not doing that right. Right. So it kind of spirals. So what can we do? All right. So establish that therapeutic relationship with the family. Okay. Let them talk. Let them express their feelings. Let them get whatever it is they need to get out. Let them get it out. Okay, if a mistake has been made, if something has happened, apologize. Like own it. Like, yep, you know what? You're absolutely right. That was, incorrect. Sorry that it was. Um, give them your time. Even if you don't have the time, give them the time that they need to get whatever it is. Develop that rapport, educate them, educate them, educate them, talk about the disease process, what's expected, what's not expected. Give them as much information as possible so that we can, you know, make sure that they have that knowledge. Doesn't always help, but a lot of times it does. Suggest support groups is another one, right? Alzheimer's support, dementia support, whatever type of support it is. Um, and allow them to come and spend as much time with with their loved one as possible, because that's often a lot of times another thing that, they feel like they're restricted in their involvement with their loved one. And that's not the goal, right? That is not the goal that we have in mind, right? We want them to spend as much time with their loved one as possible. So encourage that involvement, and just understand. I mean, it's very frustrating. And, we look at it from, our own point of view. What would happen if you had to put one of your loved ones in a facility? How would you feel, right? What would if everything wasn't as perfect? Because, you think about it, well, I could have done that better at home, right? Or if they were at home with me, this would have been this. But not everybody has that opportunity, and that's where a lot of their frustration comes into play. So we just have to, I hate to say just deal with it, and that's not correct, because I'm going to tell you, I've had to call the cops on family members before, and we've had to have family members escorted from the facility and banned from the facility. So I've been on both ends of that. Um, but yeah, just kind of understand that they're in a position where it's an adjustment. It's not only just adjustment for the patient or the client, but it is an adjustment for the family as well. And I noticed that once they get into a routine, it does get a lot better. Some families are always going to be nitpicking and I hate to say nitpicking, that's probably not the right word. They're going to always expect a little bit more, I guess would be a better word, but as long as we're providing, the quality care that we can, then you're doing the best you can. That's all we can expect. So, all right. Any questions? All right, let's take a break, be back at 4:15, and we'll go through some more delegation practice. All right, let's do some practice. I will share. All right, so here we go. So Maria, LPN, is working on a long-term care rehab unit under the supervision of Janet, who's an RN. Maria has four patients and one UAP. Right, his name is David, assigned to her. So at 9 o'clock, the following happens. All right, Mr. Owens, who is post-op day 2 hip replacement, needs his first dose of enoxaparin sub-Q and has a Foley catheter that needs discontinuing per protocol. We have Mrs. Patel, who is admitted overnight with new onset confusion, needs an admission assessment completed. We have Mr. Diallo, who is a stable COPD patient, needs a new diagnosis explained to him and his family. So he was newly diagnosed with early stage lung cancer before signing a consent for a procedure. And we have Miss Whitfield, who is a stable diabetic, needs a finger stick blood glucose and her scheduled sub-Q insulin per sliding scale. So Maria, come on, there you go. Maria is behind schedule. She asked David to discontinue Mr. Owens' Foley catheter, do Mrs. Patel's admission assessment, and just let me know if anything seems off. Sit with Mr. Diallo's family to explain what the good doctor said about the cancers. Explain what the doctor said about the cancer diagnosis since you're so good with families, and get Miss Whitfield's finger stick and give her the insulin based on the sliding scale on the wall. So, which task did Maria delegate improperly by assigning it to David? So, one, or A, obtain the finger stick blood glucose. B, discontinue Mr. Owens' Foley catheter. C, complete Mrs. Patel's admission assessment. Or D, all of the above.
C.
All of the above.
C.
D.
Absolutely.
Oh,
D,
all
all of
the
the, yep, all of the above. So, admission assessment, Mrs. Patel. Admission assessment is a licensed nursing function. RN and admission initial assessments are typically RN only. We don't ever delegate those to a UAP. Foley catheter discontinuation. This is an invasive procedure requiring clinical judgment about the urinary system. In most facilities, this is outside the UAP scope, and discontinuation should be done by or evaluated by licensed staff, not a blanket UAP task without protocol validation. Insulin. Okay, sliding scale insulin requires interpreting a blood glucose value against a scale and making a judgment call. This is medication administration requiring a license. UAPs may obtain the finger stick reading, but never administer insulin or determine the dose. Okay, so even in my situation where we have med aides and, nursing assistants and nurses, our med aides can't give insulin. Okay, that is something that is strictly done by the nurse. All right, so which of David's assigned tasks are appropriate delegation of a UAP according to standard scope of practice? So this is select all that apply. It may be one, it may be some, it may be none. I mean all. So one, obtain Miss Whitfield's finger stick glucose level. B, administer sliding scale insulin to Miss Whitfield. C, discontinue the Foley catheter. D, explain the cancer diagnosis. Or E, complete Mrs. Patel's admission assessment.
A.
Yep, so he can do that glucose level, but that is it. He can bring that glucose level back to you, and then you as the nurse, right, you're the one that is going to do that insulin administration, okay? Again, everything else is, either the RN or the LPN's responsibility. Maria asked David to explain what the doctor said about Mr. Diallo's new cancer diagnosis to the family. What is the primary concern with this delegation? A, David doesn't have a personal relationship with the family. B, delivering diagnosis information and complex teaching is outside UAP scope of practice and is a licensed provider responsibility. C, David might use language the family doesn't understand. Or D, this task should be delegated to Maria's RN supervisor instead of being done by Maria.
B.
B.
B. Yep, very good. Right? It is complex teaching. It's outside of his scope and is a licensed or provider responsibility. All right. I think this is the last question. So later, Janet, the RN, asks Maria to assess Mrs. Patel's new confusion and determine the plan of care. How should Maria respond? So A, complete a full nursing assessment and determine the plan of care since she is a licensed nurse. B, decline entirely and ask Janet to do it herself. C, collect and report data on Mrs. Patel's status to Janet since initial assessment and plan of care determination are RN responsibilities. Or D, delegate the task to David since he saw the patient first.
C.
C.
Very good. Yes. So the LPN should gather the objective and subjective data, report the findings to the RN, who synthesizes it into a nursing diagnosis and plan of care. Okay. A is oversteps the LPN scope. D repeats Maria's original delegation error by assigning judgment-based work to David. And declining entirely isn't appropriate either, just because we can, the LPN can collect the data and bring that to the RN's attention. So there, it's really just, again, following the 5 rights of delegation is going to be key in that situation. And I'm going to we're going to do some more since we have a little more time. We're going to do some more practice questions. I just have to open my book. If I can find it, it'd be even better. And then Elsevier just wants to act really slow all of a sudden. There we go. Let's see. All right. So these are going to be, I'm going to choose, I think prioritization and delegation. Actually, I'm in the wrong place. We're done. All right. All right, let's see. We're going to do delegation and prioritization. Let's see. I'm going to choose 10 questions to start with and see if we. Oh, this one's got a little bit of conflict management on here too. All right. Here we go. So question number 1. A newly hired nurse experienced harsh criticism from the preceptor during orientation. Upon completing orientation, the charge nurse assigned her the most difficult and complex patients. What would the new nurse do first? Okay, first. So 1, use assertive communication to discuss the assignments with the charge nurse. 2, talk to the nurse manager about the behavior of the charge nurse and preceptor. 3, make a formal written complaint and submit it to the Human Resources Department. Or 4, review the facilities policies on horizontal violence. What should we do first?
2.
1.
I got 2 and I got a 1. Anybody else?
I say
Okay.
1, 2.
Okay. All right, so we'll pick 1. 1 is correct. The first action would be to talk directly to the charge nurse about the assignments. This could be difficult for a new nurse, but assertive communication can be carefully planned and then delivered with a calm and non-confrontive tone of voice. The other options may also be considered if the nurse continues to experience harassment or bullying from other members of the healthcare team. So always remember your assertive communication, right? Stick up for yourself. Be respectful. Okay, so use assertive communication to discuss the assignments with the charge nurse. All right. Which assistive personnel needs a reminder on providing denture care? So one, the first AP places a towel in the sink, then fills the sink with 1 inch of tepid water. Two, the second one puts on gloves and grafts the front teeth to remove the upper denture. The third one brushes all denture surfaces with a brush using commercial paste. Or the last one rinses the dentures with hot water and stores them in a clean, dry cup. Which of those is incorrect when we're taking care of dentures?
4.
4. 4.
All right. Absolutely. So hot water can warp or soften the dentures, so tepid water is used for cleaning and rinsing. Cleaned dentures are stored in a clean labeled cup with cool water. All right. Which specimen collection method is the most important to modify if a patient has a low platelet count? So blood serum sampling for blood typing, stool sample for ova and parasites, a midstream urine sample for analysis, or an expectorated sputum sample for culture.
1.
1. Yeah.
Very good. Yep, because platelets are needed for blood clotting and a low platelet count can cause excessive bleeding. So we use small gauge needle, hold firm pressure on the site for at least 5 minutes, and then, recheck after that 5 minutes for any oozing or continuous bleeding. Good job. This kind of gave us more prioritization questions. Okay. So before the end of the shift, the nurse is rounding on assigned patients and performing a quick head to toe assessment. Which patient has the priority finding? So we have a patient with kidney stones, has a score of 7 out of 10 on the pain scale. We have an opioid naive patient that has slow, shallow respirations. We have a post-surgical patient with pale, clammy skin, or we have an elderly patient is more confused compared to baseline. Which
2.
of those
Oh, my
would
bad.
be priority? No, you're good. So we had 2. Okay. So what is it? So opioid naive. All right. So opioid naive means they've had limited exposure to opioids and it's probably affecting them a little bit more. And so anytime we're prioritizing our patient care, it's always going to be, right, your ABCs and then safety. So airway, breathing, circulation, and safety are how we follow that. So those slow, shallow respirations absolutely is going to be something that we are going to assess first. All right. Guidelines included as, or which guidelines are included as good body mechanics for lifting and moving? Select all that apply. So 1, bend forward from the waist to pick up objects. 2, use thigh, arm, or leg muscles rather than back muscles. 3, elevate the bed to work at a height that minimizes bending. 4, keep the trunk straight, don't twist when lifting. 5, use a wide base of support, feet apart at shoulder width. Or 6, push objects away rather than pulling them toward. So what are the good body mechanics?
2,
C.
3, 4, and I think 5.
2, 3, 4, 5. All right, absolutely. So the goal is to decrease stress and strain on the back muscles. So you want to use the larger muscles, your thighs, arms, and legs, rather than relying on the back muscles. Always work at a comfortable height. Minimizes bending, squatting rather than bending. Keep your back straight, maintain a wide base of support. Those are all things that are going to help preserve back function. Remember, back injuries are the number one injuries in nursing. So Be mindful of your back. Y'all are young. Save your back. Which incident would involve the State Board of Nursing in fulfilling its primary purpose? Okay. So one, we have an older experienced nurse receives less pay than a recently hired new graduate nurse. Two, nurse experiences sexual harassment from a supervisor and healthcare providers. Three, the nurse is practicing with an expired license and fails to assess a patient's cast forearm. Or four, several nurses are fired by hospital administration for trying to start a nurses union.
3.
3.
All right, good job. Yes, the primary purpose of the State Board of Nursing is to protect the public and promote safe practice by ensuring that nurses are licensed, competent, and acting within the scope of practice. All right, which documentation entry needs to be flagged so that the general guidelines for documentation can be reviewed with the nurse who made the entry? So 1330, Dr. Smith reviewed and explained surgical procedure, consent form signed and witnessed, nurse A. 1400, registered nurse assesses patient pain at 7 out of 10 on the pain scale and administers morphine as needed, nurse B, LPN. 1545, sacral wound irrigated with 100 ml sterile normal saline, pink tissue and small amount of serous drainage, notice, nurse C, LPN. And 1730, liquid nutritional supplement refused. I don't like the taste. Other flavors offered but declined. Nurse DLPN. Which of those is incorrect?
2. 2.
Absolutely. Why? Because nurse BLPN should not be assessing for the RN, right? The RN needs to come in and write her own notes. Which nurse is most likely to be held liable for nursing malpractice? I put delegation. Okay. I don't know what I did here. So nurse A assigns too many patients to the AP. Some don't get a shower. Nurse B fails to report worsening condition and the patient sustains permanent damage. Nurse C leaves before shift report. No patient is harmed, but oncoming nurses are upset. Or nurse D is demeaning and using condescending language and the patient gets angry. Which of those would be
2.
malpractice?
2.
2.
Very good. Yep. All of these nurses have failed to give high quality nursing care. However, a malpractice claim includes 4 elements: your duty, your breach of duty, causation, and damage. Nurse B had a duty to the patient, failed to fulfill that duty, and it resulted in permanent damage. All right. The nurse is supervising the nursing student who is performing a procedure. Which action by the nursing student requires correction? So 1, checks agency policy and procedural manual before beginning the procedure. 2, checks the order, collects equipment, and performs hand hygiene. 3, provides privacy, raises the bed to working height, and ensures that wheels are locked. Or 4, identifies self, starts procedure, and explains each step as it's performed.
4.
4.
All right, let's see. That is correct. The student has skipped the critical element of identifying the patient using 2 identifiers before beginning the procedure. They identified themselves, but they didn't identify the patient. All right, which patient would benefit most from a therapeutic oatmeal bath? So 1 has itching and irritation secondary to dermatitis. 2 has an open wound in the lower extremity. 3 has a fever and needs cooling measures, or 4 has discomfort secondary to rectal surgery.
1.
1. Oh, yeah. I love oatmeal baths. I love oatmeal baths are very effective. Let's try, I'm going to just go to, whoops. Let's try delegation just by itself here and see. I don't know why. Okay, here we go. Patient has a tracheostomy. Which duties can the nurse safely delegate to assistive personnel? This is a select all that apply. So, holding the tracheostomy tube when the nurse is changing the ties in the tube holder. 2, instructing the patient on how to cough effectively to remove secretions. 3, gathering the tracheostomy sterile supply kits prior to the dressing change. 4, checking the tracheostomy cuff pressure with a manometer. 5, assisting the nurse in delivering oxygen before and during sterile suctioning. Or 6, auscultating the lungs before and after suctioning the trach tube. So, can they hold the tube when the nurse is changing the ties?
Yes.
Okay. Can they instruct the patient on how to cough effectively?
No.
Okay. Can they gather the equipment?
Yes.
Okay. Can they check the cuff pressure?
No.
Can they assist the nurse in delivering oxygen before and during?
No.
Yes.
No. Yes.
Oh,
Oh,
hold on. Assist.
Assisting.
Oh, yeah.
yep.
Assist.
Assist.
Okay.
Yep.
Okay.
Can they auscultate the lungs?
No.
No. So, yep, they can definitely hold the trach tube. They can gather the supplies and they can help, right, give oxygen during the suctioning, right? So it's like having an extra set of hands, right, when you're doing the procedure. So I said, bring your CNAs with you when you got to do stuff, right? Because they're going to learn and they can help. All right. The charge nurse has delegated reading the labs of a patient with COPD to a float nurse. Okay, the patient has the following ABGs. We have a pH of 7.35, a CO2 of 48 millimeters of mercury. It's supposed to be O2 at 80 millimeters of mercury, bicarb of 28 milliequivalents per liter. The float nurse is unsure if he should take any further action based on the ABGs. Which course of action should the charge nurse suggest? So, 1, suction the patient. 2, increase the oxygen to 3 liters per minute. 3, notify the respiratory therapist. Or 4, continue to monitor the patient.
I think
4.
continue to monitor.
Okay, so 4, continue to monitor. All right, good job. Yes, normal pH is 7.35 to 7.45, so we're good. PO2 or CO2 75 to O2 75 to 100. Okay, O2 is 80. Your PaCO2 35 to 45, it was 48. And then your bicarb normal is 22 to 26, and it's at 28, right? So they're essentially normal. Okay, so good job. All right, the nurse has delegated all the personal care of her patients to the assistive personnel. Which of the following situations would warrant the nurse to give additional guidance to the assistive personnel? 1, a patient with COPD who is reclining in a chair at a 120-degree angle. 2, a patient with tuberculosis in a negative pressure room with the door closed. 3, a patient on a clear liquid diet who is eating a popsicle. Or 4, a patient with viral pneumonia being transported to x-ray with a surgical mask on. Which
1.
of those?
1.
There you go. Absolutely. Patient with COPD should be placed in a Fowler's position or leaning forward to help with breathing, right? Don't want them all the way reclining or anything like that, right? That's just going to decrease their ease of breathing. Good job. All right. We have a post-op patient with a tonsillectomy. Vital signs upon returning to the unit were temperature 98.7, pulse 76, respirations 20, blood pressure 134 over 72, O2 sats 98% on 2 liters of oxygen, and have remained stable for the past hour. Which post-op duty should not be delegated to the assisted personnel? 1, check vital signs every 30 minutes for 2 hours. 2, position the patient in a semi-Fowler's position. 3, assess the patient for frequent swallowing. Or 4, place an ice pack around the neck. What can we
3.
not delegate?
3.
3.
Very good. Yes. Now, they can't assess the patient for frequent swallowing, but what can they say? They can come to you and say, hey, they're swallowing a lot. But yes, no, they can't assess. They cannot assess. Now, most of your CNAs that have been a CNA for a long time, right, they're going to bring attention to you of some of those things that we need to worry about. So good job. I believe I have some more practice questions. I can put those in the announcements so that you can continue to, practice. But your book, what is it? I always forget the name of it. The nursing delegation and management of care book that you guys have. There are additional practice questions in that. Have you guys registered that book and got like your code and stuff? If you register your book with your code in Evolve, that'll give you some additional practice questions as well. So I always suggest that.